welcome to this clinical pathological conference, which is funded by American Heart Association and will appear on the website of our journal, Hypertension. I should introduce myself. My hat today is that of Editor-in-Chief of Hypertension, and we're very privileged to have seven associate editors and one guest editor of our journal. Those of you who do not read every month's Hypertension should know that it is the best journal in our area in the world, with the highest impact factor and the biggest number of readers. So we're very privileged to have them today in Glasgow and to record this clinical pathological conference. For the younger members of the audience, this is like New England Journal of Medicine. That's what we're going to do. There will be the same way of presenting the case, answering difficult questions, having a discussion and debate of the experts. But you also very much invited to ask questions. There are no silly questions. All questions are good. So don't be shy. Ask questions. We have also a local team of hypertension experts hiding here and there. Sandosh, Christian, Tom, Guzik. Ask questions, contribute. You'll be in the film. We also will publish this as a paper in Hypertension in due course. So without any further ado, we will proceed with our first presentation and first case by Dr. Marie Friel, an unusual case of mineralocorticoid hypertension. Marie.
Thank you very much, Anna. I would also like to extend my welcome to the editorial team of Hypertension, and glad that the weather in Glasgow has reverted to type. We had 24 hours of sunshine and we were all slightly disorientated, so we're back to normal service. So I changed the title of my talk slightly because I felt the title gave it away, but Anna has now given the title away again, given the diagnosis away, so most of you now can go to sleep. But I work as a senior lecturer here in the university, as well as a consultant endocrinologist in the Western Infirmary, and I am part of the blood pressure team there. My focus and interests are primarily in endocrine hypertension, hence today's case. So this case starts fairly benignly with our 42-year-old gentleman who attended as general practitioner, complaining just primarily of fatigue and generalised weakness, a very, very common complaint. He had a past history of myocarditis about 10 years previously, which had resolved spontaneously with treatment and supportive therapy, and at that point was labelled as having essential hypertension. Now, over the years, his blood pressure had been well controlled, albeit with 3 agents, all of which are listed today. Importantly, he had no family history of hypertension, and on examination the GP could find really nothing relevant on physical exam other than hypertension, so significant hypertension that was sustained and had previously been well controlled. The GP performed some routine biochemical tests and he was found to have significant hypokalemia, so potassium of 2.3 millimoles per litre at presentation. And what's interesting about this is that this gentleman had had a series of biochemical tests for unrelated causes in previous years, and you can see that his hypokalemia was new and serum potassium had been normal in the preceding years. So we have a 42-year-old gentleman with a 10-year history of well-controlled hypertension, which is now worsened, and with new and persistent hypokalemia. So at this point, I would turn perhaps less to our expert, because I would think that the main differentials might be clear, but perhaps the general audience and more junior members of the audience as to what would be the 2 most likely underlying differential diagnoses in this gentleman with hypertension and hypokalemia. We may have to turn to our expert panel, but I would like not to have to. The clue is in the endocrinologist as the presenter. An expert opinion.
What is the role of diuretic therapy in the hypokalemia?
Yes.
And the other question I have as a hypertension specialist, why do you give furosemide Why do you use a loop diuretic instead of a thiazide?
And both are very good questions. So first of all, I should say that his furosemide was discontinued and his potassium was rechecked and it remained low. And that is a very good point. In our defence, he came to us as a tertiary referral. We would always use thiazide diuretics, and particularly in someone with normal renal function. But that's entirely correct. We did change his diuretic to a different alternative agent, I think an alpha blocker actually. But that's entirely reasonable. Professor Jennings.
Just on that, perhaps the furosemide was a leftover from his myocarditis in the past.
Possibly. I think this chap had very intermittently attended his GP over the years, and it was a sort of historical treatment. I think that's reasonable.
Do you have any insight into the renal hemodynamics, like creatinine? Is it high, low, normal?
It was normal. So the only abnormality on his routine biochemistry was hypokalemia, which was new.
Madam Professor, what do we know about aldosterone?
There we go. No, we don't yet, but we soon will. So yes, I mean, I think...
I would say that you asked for the two diagnoses, and nobody gave them yet.
No, they did not.
And of course, primary hyperaldosteronism is one, and the potential for renal artery stenosis that could also be associated with hyperaldosteronism and hypokalemia are the two diagnoses that one would consider.
Yes.
So the winner is
Professor Schifrin. Yes, as expected, he wins the prize.
I mean, the third is secondary hyperaldosteronism in response to licorice or some other iatrogenic.
Yes, and we certainly can discuss all of these, but Professor Schifrin is entirely correct in that statistically the most likely causes of this gentleman's hypertension and hypokalemia would be primary aldosteronism, which we now know accounts for at least 10% of people with unselected hypertension, probably 20% of people with resistant hypertension, which you could argue this gentleman has, or renal vascular disease, which is particularly prevalent in patients who present with malignant phase hypertension, which he probably didn't quite have. So I would agree that statistically these are the most likely underlying differential diagnoses, and I would also agree that the next most reasonable test would be assessment of this gentleman's Renin-Angiotensin-Aldosterone System. And again, it's important, as has been pointed out, to think about the role of drug therapy here and how it has to play a part in the interpretation of renin and aldosterone. And so again, it's very important to point out that this plasma renin concentration and aldosterone were measured off diuretic therapy. It's also important to note that at this point his hypokalemia had been corrected by exogenous potassium, because persistent hypokalemia can result in sort of falsely low levels of plasma aldosterone. So perhaps surprisingly, his plasma aldosterone levels were actually low. And again, his plasma renin activity was also low. So these were probably not what we would expect, and these are certainly not in keeping with the diagnosis of primary aldosteronism, in which case renin should be suppressed but aldosterone should be high, or at the very worst, high normal. And in renal vascular disease, where you tend to get a secondary hyperaldosteronism. And so I thought at this point it would be appropriate to perhaps revise all these syndromes with which you're all very familiar that can be associated with hypertension and hypokalemia, and their effects on the renin-angiotensin-aldosterone system. And I think we've already effectively excluded the top two and the most likely two by the suppressed plasma renin and suppressed plasma aldosterone concentrations. A renin-producing tumour would have been unlikely but possible, but again is pretty much excluded by the absence of secondary hyperaldosteronism. So then we're left with these other diagnoses, one of which has been mentioned because the syndrome of apparent mineralocorticoid excess, as we'll talk about, can also be mimicked by exogenous licorice. But these bottom five fairly rare abnormalities can all be associated with hypertension and hypokalemia with suppressed plasma renin and suppressed plasma aldosterone. And what I thought I would do, perhaps with your help, is have a chat over the next few slides about the likelihood from clinical and other evidence of these as underlying diagnoses. So we'll start with Liddle's syndrome, which is a very rare autosomal dominant condition where there is constitutive activity of the epithelial sodium channel of the distal convoluted tubule of the kidney. And this results in continual reabsorption of sodium from the urine and continuous secretion of potassium, and therefore in mineralocorticoid hypertension, but with volume expansion and hence suppression of aldosterone and renin. And although this remained a possibility in terms of an underlying diagnosis, we thought a genetic abnormality in a gentleman in his mid-40s with previously normal potassium and previously normal blood pressure, albeit hypertension that developed in the early 30s, would make this less likely. This tends to be a disorder that presents in childhood with significant hypertension and hypokalemia, but there have been case reports of Liddle syndrome presenting in later life and sometimes not even associated with hypokalemia. So we felt this was unlikely, but was not absolutely impossible. Cushing syndrome, to me as an endocrinologist, is always an interesting and possible underlying diagnosis. And Cushing syndrome, as we know, is a rare disorder, but Cushing syndrome due to ectopic ACTH can be associated with hypokalemia in up to 50% of cases. Now, ectopic ACTH as a cause of Cushing's is a rare cause in itself, but we felt we were probably looking at rarities in this case. Now, our clinical suspicion of Cushing's was low with this gentleman. He did not have any Cushingoid features. He did not have bruised, thin skin. He did not look overtly pigmented, which is often the case in ectopic ACTH. And he had no striae or proximal myopathy. And these are really the key clinical features that would increase our clinical suspicion of Cushing syndrome. But nonetheless, as a precaution, we did perform some simple screening tests of cortisol excess, all of which were normal. So he suppressed his early morning cortisol level to a normal, less than 50 nanomoles per litre with dexamethasone, and he had a normal 24-hour urinary free cortisol. Yeah.
Yeah, I think it's important to mention the ectopic ACTH production because it often presents with very few manifestations of the typical Cushing syndrome, but severe electrolyte abnormalities and profound weakness, muscle weakness associated with very severe hypokalemia. And so it is a consideration in a patient who presents, and I've seen a patient exactly like that, who had a lung tumor secreting ACTH or ACTH-like peptide with potassiums of 2.4, 2.3, which are quite unusual.
No, I think that's an excellent point and entirely true. And we had a similar case, I think Professor McMurray was involved in, of a man with bronchial carcinoid, and it was near the heart, and he had pericarditis, and he had really significant hypokalemia and skin pigmentation. But apart from that, had no other classic features of cortisol excess. So I think that's a very good point, and I think further justifies the assessments of cortisol dynamics in this gentleman. Unfortunately, or perhaps fortunately for him, they were normal. So we're now left with these rare and wonderful syndromes that could have resulted in this gentleman's hypertension and hypokalemia. We've mentioned Liddle's, and these other three syndromes are also very rare autosomal recessive genetic disorders that are associated with abnormalities in corticosteroid biosynthesis. So I would welcome some suggestions from the audience as to what investigation they would recommend now, perhaps to exclude these unlikely but possible diagnoses once and for all.
Were there data on 24 hours urinary corticosteroids, or was there imaging of the adrenals?
Yes, so that's where we're coming to. So that's exactly right. It was very important that we performed a 24-hour urine collection to look at this gentleman's multi-steroid profile and look at his urinary corticosteroid biosynthetic pathway. So that's exactly what we did. And this is a slide that, again, will just remind you all of corticosteroid biosynthesis in the adrenal cortex. And this consists of a variety of biosynthetic steps, starting with cholesterol and ending in the zona glomerulosa with aldosterone, in the fasciculata with cortisol, and in the reticularis with adrenal androgens. The boxes highlighted in yellow and in bold are the three corticosteroid metabolites that were significantly elevated in this gentleman's 24-hour urinary steroid profile. And these metabolites, deoxycorticosterone or DOAC, deoxycortisol and corticosterone, are all potent mineralocorticoids, all of which bind and transactivate the mineralocorticoid receptor. And it was the significant elevation of these mineralocorticoid metabolites that were causing this gentleman's mineralocorticoid hypertension, but were suppressing his plasma aldosterone levels. And the next question then is, why were these elevated? And so very quickly I'll run through why it was not due to any of those rare genetic disorders that we've mentioned in the table. So 17-hydroxylase deficiency is a rare autosomal recessive form of congenital adrenal hyperplasia whereby glucocorticoids and androgens cannot be synthesized within the adrenal cortex. So there is compensatory increased production of mineralocorticoids, but of all 3 mineralocorticoid precursors, including 18-hydroxycorticosterone, which was not elevated in this gentleman. So although clinical suspicion was very low, the biochemical profile did not fit with this disorder either. 11-beta-hydroxylase deficiency, again, is rare, but a slightly more common cause of congenital adrenal hyperplasia, where mineralocorticoid hypertension develops because of elevated DOAC and deoxycortisol because of this enzyme 11-beta-hydroxylase fails to work adequately. And again, you can see how the steroid profile does not fit with this. And finally, the syndrome of apparent mineralocorticoid excess develops because of a deficiency in this enzyme, 11-beta-hydroxysteroid dehydrogenase 2, which converts cortisol to its inactive metabolite cortisone, because cortisol binds and transactivates the mineralocorticoid receptor as avidly as aldosterone and is present in far higher plasma levels. And so without this enzyme, the MR would be activated continually by cortisol. And in the absence of this enzyme, cortisol is not deactivated and therefore binds and stimulates the mineralocorticoid receptor. The same effect occurs with eating licorice. Licorice inhibits this enzyme, as does the old-fashioned drug carbinoxolone. And these together cause this syndrome of apparent mineralocorticoid excess, which is characterized by an elevated cortisol to cortisone ratio. And that was not present in this gentleman's 24-hour urinary steroid profile. So we seem to have ruled out all our little differential diagnoses for hypertension and hypokalemia, apart from one obvious potential underlying cause that was mentioned by one of our expert panel members. So all that was left to think of here was that this gentleman had to have a disruption of his normal adrenal cortical architecture and zonation, and therefore in all likelihood this gentleman had an adrenocortical tumour that was producing mineralocorticoid precursors. And so absolutely we moved on to image this gentleman's adrenal glands. And just up in the corner, just to remind us as to what a normal CT scan of adrenal should look like, the adrenal glands are tiny retroperitoneal glands that look like inverted Ys. And you can see we don't need to have any major expertise in radiology to see that this gentleman had a large 7.5 centimetre heterogeneous adrenal neoplasm on the left side.
So when one has such an abnormal production of metabolites by the adrenals, should one think specifically in some type of tumor?
Yes, essentially yes, unless the patient in question was a neonate, in which case one of those inborn or congenital abnormalities would be likely. But in adulthood, patients presenting with this very odd pattern, it's really only going to be an abnormality of architecture. So absolutely.
What you mean by that is not a benign tumor.
Not a benign tumour, that's entirely true. And and that's sort of confirmed by the radiological appearance here of this tumour, which by size alone would suggest, so benign adrenal tumours tend to be less than 4 centimetres, they're homogeneous, and so by size alone, not even by clinical presentation, this was likely to be a malignancy. So this was indeed a case of adrenocortical carcinoma. And this patient underwent a laparoscopic left adrenalectomy and nephrectomy around 2 years ago by Professor O'Dwyer, who will comment on the operation in just a minute or two. In terms of pathology, and I'll show you some slides in a few minutes, unsurprisingly the pathology confirmed adrenocortical carcinoma. Pathologists use something called the Weiss criteria to confirm adrenal malignancy, and there are 9 Weiss criteria, more than 3 suggest malignancy. This gentleman had 6 positive Weiss criteria. Encouragingly, he had an intact capsule and the excision margins looked clear, and so in pathological staging, this was a PT2 N0 M0 cancer. And this is a picture of the gross pathology of the adrenal tumour. It's stained with India ink. It isn't black. It's stained with India ink to show clear excision margins with the adherent kidney. And at this point, I'll hand over to Professor O'Dwyer, who will give us a few comments about the operation.
I think you may wonder why we took out this gentleman's kidney, but the CT scan didn't show you that it wasn't a cut across the pedicle, but if you could have seen a cut across the pedicle, you'd realize that his vascular pedicle is involved with this tumor. And I think, Maria, if you just show he's also got a premalignant lesion in his kidney. You see the upper pole, you see it down. There.
Might need the,
There. He's got a Bosniak grade 3 lesion in his kidney. So he had two good reasons for having a laparoscopic adrenalectomy and nephrectomy. Even though this is 8 centimeters circumferentially, you can see it's a lot longer than that. So his tumor is about 12 by 8 centimeters. So it's a very big adrenal tumor.
Would it be worth commenting on laparoscopic versus open adrenalectomy in this situation with a big tumour and a malignancy?
We attempt laparoscopic adrenalectomy on everybody, and the reason for that is both the view you get, particularly on the right side, you can operate much, much better on the right-hand side than doing an open. A very large one on the right-hand side would require a thoracoabdominal excision to get you the same access to a large right adrenal tumour, but laparoscopically we can mobilise it and put it up over the right lobe of the liver, and getting at the cava is the key thing. And what we find that if you're doing that at open surgery, of course you're using your hand, and these are necrotic tumours, and it's quite easily perforate these tumours. And if you look at our actually data, I don't think we've perforated any tumour laparoscopically because the dissection is so much more gentle. And the other thing, in over 400 adrenalectomies, we haven't seen a local recurrence yet. And 40% of our tumours are greater than 6 centimetres that we operate on.
Do you know where the first... Do you know where the first laparoscopic adrenalectomy was performed?
Yes, I do, yes. Yeah, it was published by, I can't remember his name, but it was published in the New England Journal by, what's his name again?
I can't remember, but it was done.
I can't remember either.
In Montreal.
Yeah.
At my hospital.
Yeah. No, it wasn't. No.
Maybe we can discuss this off camera after.
I check his name on my page, but it's done. It's not Montreal, not published. That's for sure. Not published.
Thanks, Paddy. So, and really just to sort of confirm, let's just show you just some of the histological slides. So the slide on the left just shows you that this was a highly vascular cortical tumour. And these cells were arranged as nests and sheets quite nicely, and there was some resemblance to normal adrenal cortical architecture. And the slide on the right is an immunohistochemical slide, which showed that these cells stained strongly for inhibin, which confirms they're of a cortical origin. One of the Weiss criteria is the presence of mitotic figures, and that's an example of a mitotic figure just in the centre of the left-hand picture. And on the right, you can just see this tumour invading, in fact taking over an associated blood vessel. So vascular invasion is another Weiss criterion. So, as mentioned, this gentleman underwent adrenalectomy and nephrectomy just over 2 years ago, and within a month, his 24-hour urinary corticosteroid profile had returned to normal. And his blood pressure was now normal on 2 agents, and his plasma potassium was back to normal. So biochemically, and indeed clinically, there was a marked improvement almost immediately after surgery. Adjuvant therapy of adrenocortical carcinoma is very topical, and we might touch on that just at the end. But after surgery, because of the size of this tumour, he underwent radiotherapy to the adrenal bed. And it was also worthwhile because he'd now lost his kidney, so damage to the kidney is a concern with radiotherapy, but he no longer had a kidney. And he was treated with a drug called mitotane, which we can discuss in a little more detail just at the very end. How did he do? So we're just over 2 years on. And unfortunately, 2 months ago, with routine imaging, this gentleman developed a solitary liver metastasis. And again, Professor O'Dwyer was called into action and performed a resection of this liver metastasis, I think just in May. And again, the pathology is just here to show you. So normal liver architecture on the right, and this was the metastatic lesion on the left. And I think you can remember from a couple of slides back, it's very similar to the original histology of the original adrenocortical tumour. So his hepatic metastasis has been entirely resected, again with clear excision margins, and currently he remains disease-free. So adrenocortical carcinoma is a very rare, thankfully a very rare malignancy, 1 to 2 cases per million per year, slightly more common in women. And I say it's thankfully rare because the prognosis is very poor. The current figures quote a 7% 5-year survival rate for patients who present with stage 4, i.e. metastatic disease at presentation. For someone like our gentleman who probably presented with stage 2 disease, he has about a 50% 5-year survival. The majority of tumours are secretory and therefore are often picked up because of clinical features of generally cortisol excess or of cortisol and androgen excess. A small number are purely androgen-secreting tumours, and we see some of them particularly in women who present with aggressive virilization. Rarely do we see an adrenocortical cancer that produces aldosterone, and I have never, and I'm unlikely ever to see again, an adrenocortical cancer that presented purely with excessive production of aldosterone precursors. So adrenocortical carcinoma is rare in itself, but an ACC that was secreting mineralocorticoid precursors is extremely unusual. And I've mentioned adjuvant therapy. So the only curative therapy of adrenocortical carcinoma is obviously surgery. And surgery is recommended in all cases, even potentially in cases with metastatic disease at presentation. Because it's a rare cancer, prospective trials of management of adrenocortical carcinoma are lacking. But this is probably one of the best that we have, that was published now 7 years ago by Touyz in the New England Journal. And this was a prospective trial looking at the use of mitotane versus no mitotane in patients who had undergone apparently surgical cure for their adrenocortical carcinoma. Some of you may have used mitotane. It's an adrenolytic drug. Its mechanism of action isn't entirely clear, but we use it quite commonly in the management of adrenocortical carcinoma. It can also be used as a medical treatment of Cushing syndrome as well, because it inhibits adrenocortical activity. And this was a trial of patients who had undergone surgery, and a group in Italy were just treated per chance with mitotane, and 2 groups in Germany were not, and they were followed up for quite a long period of time, and you can see a significant improvement in recurrence-free survival in the mitotane group and also in overall survival. And it's because of these data that we now use mitotane routinely post-operatively for a period of up to 2 years in all patients who have undergone resection of their adrenocortical tumours. In terms of radiotherapy, again, the data are lacking, and there has been no prospective randomised trial of the use of radiotherapy in adrenocortical carcinoma. There are lots of retrospective trials that do suggest benefit, particularly in tumours that can be deemed high risk. Advanced adrenocortical carcinoma is a dismal disease with, as I say, a 5-year survival rate of about 7%. And again, data are lacking as to the optimal treatment because of small numbers, and this is probably the best trial that we have, the FIRM Acth trial, randomised trial of locally advanced metastatic adrenocortical carcinoma that was published again in the New England Journal around 2 years ago. 304 patients, which for adrenocortical carcinoma represent quite a big cohort. And these were patients who were all treated with mitotane, because after the Touyz publication, mitotane has always been used. But these were patients with metastatic or advanced disease who were given mitotane plus either this chemotherapy regimen or mitotane plus the old-fashioned drug streptozotocin. And I'll show the data here. First of all, really just to illustrate the dismal prognosis associated with advanced adrenocortical carcinoma. So this is progression-free survival, and you can see, a statistically significant improvement in progression-free survival with the EDP mitotane combination, but it's 5 months versus 2 months in the other group. And there was a trend, but there was no significant change in overall survival. Overall survival, 15 months for the EDP mitotane group versus 12 months in the streptozotocin group, and 3/4 of these patients were dead by the final analysis. So I'm sorry to finish on a fairly depressing note, but just to summarise, this was a case of worsening hypertension, but with new hypokalemia that was driven not by aldosterone, but by mineralocorticoid precursors from an adrenocortical carcinoma. As mentioned at the beginning, in the vast majority of these cases, assessment of plasma aldosterone and renin would confirm the underlying cause of hypertension, and it's most likely to be either primary aldosteronism or renovascular disease. And again, to emphasise that thankfully, because of the poor prognosis, adrenocortical carcinoma is rare, but a pure mineralocorticoid producing adrenocortical carcinoma is vanishingly rare, and I would welcome the opinions and the experiences of our panel regarding that final point. Thank you.
Right, I think that Professor Stassen found the name of the person who did the first procedure, laparoscopic procedure, and it is, can we get the mic? And it is?
Okay. It was Michel Gagné at Hôtel Dieu Hospital in Montreal in 1992, published in the New England Journal of Medicine.
Okay, so this is now 2-0 to Professor Stassen, right? Schifrin, sorry. It will all be nicely done when we edit the film, right? Okay, so are there any burning questions for Marie and any other opinions? We've got one.
Yeah. Two questions. And the first question is, are you aware of markers of a very bad, very poor prognosis? I'm aware of a publication that microRNA 210 would be predictive of a very, very poor prognosis. And the second question, there is a European network, NSAT, where for, yes, when you're faced with an adrenal mass, do you follow these recommendations? For instance, what they always say, that you have to look for an associated second or third tumor, for instance, a FEO. There are associations with pheochromocytoma. Do you follow these guys, or what do you think about these guidelines or recommendations?
Yes. So yes, we are in Glasgow. So we are members of NSAT, and we find the recommendations very, very useful, particularly in the management of adrenocortical masses, which we see lots of now on routine imaging, and they comprise a large number of referrals to the endocrine clinic, and the NSAT guidelines are very useful. And I think again you point out an important point, that before we let Professor Dwyer let his laparoscope go near any adrenal mass, we always exclude catecholamine excess first, irrespective of the imaging phenotype, which is usually fairly helpful in trying to discriminate that. But irrespective of the imaging phenotype, some sort of assessment of catecholamine production always has to be done. In terms of criteria to try and predict bad outcome, I mean, obviously staging it at presentation will help do that. I mean, microRNA is obviously very new, and it's not something that we certainly do routinely in our adrenal tumours, although it's something that we're looking to do as part of the NSAT network. But certainly the briskness of the tumour, the Ki-67 index is one indicator which we tend to use, and just the number of positive Weiss criteria, the size of the tumour, and as I say, the stage at presentation. But we've seen stage 1, stage 2 relapse very, very quickly, and so staging isn't always helpful. And I think it's also difficult at stage 1, stage 2 disease to know, is adjuvant therapy merited? And that's part of the reason why there's a trial ongoing just now, the Adjuvant Trial, about whether mitotane should be used in stage 1 disease, and Glasgow's a centre for that trial as well. So I think there's a lot we don't know, but membership of NSAT is very helpful in trying to help improve our knowledge in that area.
Okay, any other points? Ernesto?
Yeah, perhaps going back to primary aldosteronism, would you like to comment on some of the mutations that occur in channels that may have a bearing on the development, perhaps, of adrenal adenomas, aldosteronomas?
Yeah, no, thank you. That's been a hugely burgeoning area over the last couple of years, since there was a paper in Science from Rick Lifton's lab, I think about 3 years ago now, that showed that there were somatic mutations in a potassium channel in about a third of patients with adenomatous primary aldosteronism. And these were also identified in the germline of this very rare syndrome that had been identified in a father and 2 daughters who had massive adrenal hyperplasia and massive mineralocorticoid hypertension in childhood. And since the original Rick Lifton paper, with the help of NSAT and other European adrenal tumour associations, there has been a lot of work looking at channels and looking at the genetics underlying adenomatous, not the bilateral forms, but adenomatous primary aldosteronism. And I think there have been mutations now identified in about roughly about 40% of tumours. KCNJ5, which was the original mutation discovered in Rick Lifton's lab, is the most predominant one, and it results in loss of selectivity of the potassium filter, so that the adrenocortical cell is constantly activated and hypertrophies and proliferates and produces aldosterone. But there have been mutations identified, I think, in calcium channels and in ADP channels, and in genes that are concerned with ADP metabolism. So a hugely exciting, a huge growth area really over the last maybe just 2 to 3 years, but kicked off in the Rick Lifton group, as many of these are.
Okay, any other points from the audience? No, I think we've exhausted that case of aldosteronism, or rather non-aldosteronism. Thank you very much, Marie.